There's several methods to determine the axis, and one would be to look at an isoelectric lead, and right angles to that lead would be the axis. But at times there's no lead like that. Another method would be to look at the leads 1 and AVF. It's like looking at the net QRS deflection in these leads, and in case of a normal axis, the QRS deflection is positive in leads 1 and AVF. In right axis deviation, the net QRS deflection is negative in lead 1 and it's positive in lead AVF. In left axis deviation, the net QRS deflection is positive in lead 1 and negative in lead AVF. And in a situation where the net QRS deflection is negative in leads 1 and AVF both, it's termed as a indeterminate axis. But the leads are representing different electrical magnitudes, and often there is an error. And there's another method where you start with a triaxial system, and what's done is basically all the leads are reduced to a common center. What you do is basically you take two leads, any two leads, and look at the deflections, and then you take the algebraic sum of the deflections in those two leads, and then go ahead and then mark that amount on the lead as represented appropriately. And from those marked points, you drop perpendiculars and look at the point of intersection, and then draw an arrow from the center to that point of intersection, and that's the axis. It's like looking at the mean vector of two forces. And what can be noticed are a few logical things those emerge after trying several values on this kind of method. Is one is that when the negative value of lead 3 is greater than the value of lead 1, which is positive, then the axis would lie on the left side of minus 30 degrees, and lead 2 would be always negative in this setting. Whereas if you look at right axis deviations, some observations would be seen, such as if you make lead 1 as 0, then the axis must be pointing straight up or straight down. That's like plus or minus 90 degrees. Or if the 2 and the 3 leads are positive, they have a plus value, then in that situation the axis would be pointing downwards, that's towards positive 90 degrees. And several other values can be looked into by trying to play around with the values and then trying them on sheet with this triaxial lead system. Some reasons for development of left axis deviation would include an inferior MI, or a left anterior fascicular block, or as in left ventricular hypertrophy. Right axis deviation can be seen with acute pulmonary diseases such as pulmonary embolism or pneumothorax, or in right ventricular hypertrophy, or as in left posterior hemiblock. One needs to correct for the body habitus and age before deciding a normal axis. For example, in infants, the axis to the right of 100 degrees would be normal, as infants are born with the rightward axis due to a high pressure in the pulmonary circuit during fetal life. And during life, the axis tends to move leftwards, so that in adults, an axis of 0 degrees or even slightly minus is common. Then in tall and slender people, the position of the heart would be near vertical, and because of that, they could have a rightward axis. And similarly, in short and stocky people, the heart tends to lie out to the left, and at times it's horizontal almost. And therefore, short, stocky people would have a left axis commonly. So it's kind of important to keep in mind the age and the body habitus, and to come to a conclusion of what is a normal axis versus what is not. Talking about the ventricular hypertrophies, when looking at a left ventricular hypertrophy, a few things are important to keep in mind. One being the R wave. It's noticed that more the heart muscle is thick, the taller the R wave it would tend to produce. So an abnormally tall R wave would be an important criteria of hypertrophy. And what's seen is that abnormally tall R wave on one side would lead to an abnormally deep S wave on the opposite side. So therefore, in hypertrophy, excessive voltages, positive or negative, would be a key criteria. And if there is an abnormally tall R wave on one side of the electric field of the heart, that would mean that there will be an abnormally deep S wave on the opposite side. Another feature would be the deviation of the axis towards the myocardium where it's thickest, and therefore in a left ventricular hypertrophy there would be a left axis deviation. And as we look over the leads over the hypertrophied ventricle, what would be noticed is a typical Sdt configuration. And what's seen in this Sdt configuration is that the T wave would be inverted, and it would have a slow descent and a rapid upstroke, and the descent would be low and slow, and the upstroke would be rapid. It would be more like a hockey stick configuration, and the ST segment would be downsloping and depressed. So it's a peculiar STT configuration. Another thing that's noticed is that in a thickened myocardium, the time that R wave takes to complete its rise from base to the peak would be longer than the normal. And this is called as the time of onset of intrinsicoid deflection. The STT configuration mentioned before is also called as the strain pattern. Now, these concepts were put together by Rome-Hilt and Estes, and they developed a point score system for detection of left ventricular hypertrophy, and they incorporated the term increased voltages as one of the components. And increased voltages would mean 30 mm in precordial lead and 20 mm in limb leads. Sokolow and Lyons conducted a study and they said that left ventricular hypertrophy was likely to be present if the sum of the S wave in V2 and R in V5 equal 35 mm. And there were subsequently other studies also, and those studies kind of added voltages in AVL greater than 11 mm as a criteria of left ventricular hypertrophy. So many different ECG criteria exist, and ECG may be suggestive of left ventricular hypertrophy. But a common ECG standard would be an increase in the Qrs voltage plus in evidence of either strain or left axis deviation or left atrial abnormality. Now, increased QRS voltages would be evidenced by a R or S greater than 20 mm in any limb lead, or by S in V1 to 3 or R in V4 to 6 greater than 30 mm, or R in V5 plus S in V1 greater than 35 mm, or R in AVL greater than 11 mm. Then the strain would be denoted by non-specific STT changes, which would incorporate usually mild downward sloping ST depression and T-wave inversion or biphasic T-waves. Left axis deviation can be determined by any of the methods as mentioned before, and then the left atrial abnormality, where there would be a net negative P wave in the V1 or at least slightly biphasic P wave in V2. Well, thinking of the right atrium as the anterior atrium and the left atrium as the posterior atrium, and keeping this in mind and then looking at the P wave in V1 in the ECGs, one would realize a small upward deflection that is followed by a small negative deflection. Now the right atrium is anterior, therefore the wave activating it will move towards the V1, and therefore this upward deflection. And similarly, the left atrium is posterior, and there would be a negative deflection when looked at V1. And there would be an atrial abnormality if P wave encloses in area of at least 1 mm square.